Okay, sorry about that abrupt ending. To the last one. I wasn't watching the timer, and these only tape for 15 minutes. So, the last thing on this slide was talking about a heave or a lift. This is something that you may see. We're looking for something called the apical impulse, and we're going to talk about that in a second. But again, that's over that area of that fifth intercostal space, and you may actually see lifting of the skin or heaving up of the skin. It's caused by that thrusting of the ventricle, that forceful thrusting. So the apical impulse, if you look at your book on page 479, it talks about the apical impulse being created as the left ventricle rotates against the chest wall. So during systole, so during the working phase of the heart. So you may actually see, not only feel the pulse over the apex of the heart, hear the apical pulse, but you may actually see it or be able to kind of feel it. So not everybody has it where you are able to feel it. So when you examine your partner this week, you may be able to feel it, you may not be able to. So again, asking them to exhale and hold it, that'll help with that. Sometimes they may need to roll to the left, but then you have to go a little farther to the left than at the typical apex part. So palpable in about half of adults, and patients who have high cardiac output, the apical impulse increases in amplitude and duration. So those are people who have anxiety, high blood pressure, hyperthyroidism, all those types of diseases. So palpating across the precordium, again, that area of the chest wall that is above the heart and the great vessels, you're going to use the palmar aspect of your four fingers. So you're going to be using, if I have this up here, I'm going to be using this area. Gently palpating, so you can see I'm using that aspect. You're going to palpate in the apex, the left sternal border, and the base, searching for any other pulsations. Usually you won't find any. It's normal not to find any. If there are any, time them, count them, see what they are, and then you can also feel the carotid artery at the same time and notice if the pulsation is equal to the what you feel for a pulse in the carotid artery. You may also feel something called a thrill, which is a palpable vibration. So you will actually feel like a little vibrating on the skin. I don't know if any of you have ever seen a patient who gets dialysis and they have their shunt in place in their arm. Well, in that shunt area, it often has this vibrating feel to it. If you ever get a chance to feel that over a patient's arm, that's something that would be good for you, and it almost is the same type of a feeling, just kind of a palpable vibration, and there's again that turbulent blood flow underneath that area. Auscultation, so listening, we are going to be listening over 4 different areas: the aortic area, pulmonic area, tricuspid area, and mitral area. Now, these are where, so when we hear over these areas, the stuff we hear, we're not actually hearing the valves themselves closed. Even though we have an aortic valve and a pulmonic valve and tricuspid, they're in that general area that we're auscultating in, but they're not actually the valves themselves that are causing those sounds. So, we're going to be looking for the aortic valve area. It's in the right side of the chest, second intercostal space, and right close to the sternal border. The pulmonic area is in the second interspace, closer to the sternal border. Actually, both of them are more mid-clavicular, I guess, so more along the middle of that clavicular area. And again, second left interspace. The left lower sternal border is the tricuspid area. And it's right along that's the one that definitely is right along that area. And it's usually between the third and the fourth rib or intercostal space, so right in that area. And then the mitral area is the fifth interspace. So going down 5 intercostal spaces, and again we're going to that midclavicular line. So know those areas. There's a nice picture on page 480 that shows these areas for you. And it's important for you to know those. You are going to be responsible. So please don't put, though, when you're documenting these, don't put aortic valve, don't put pulmonic valve when you're doing your write-ups. You can say aortic area or pulmonic area. You can say aortic valve area, that's fine as well, but we only really need the aortic area. But you will be marked off if you say aortic valve or pulmonic valve, because it's not truly the valves that we are actually listening to. Also, if you look on page 480, there's a fifth area that we listen to, and that's called Erb's area. And you'll see that that place is usually in the third intercostal space, just to the left of the sternal border. So here's that picture that you would normally see. I'm moving not sure if you can see me move my mouse, but there's pulmonic, there's aortic, here is Erb's, mitral, and tricuspid. This over here is more an updated version, but I think it's a little bit more confusing as you learn it. This will come a little bit easier for you as you learn how to do these assessments a little better. So for right now, just focus on this one. Okay, auscultation list. We're not only listening to those 4 areas, but we do want to listen over those 4 areas. Actually 5 when we listen over the Erb's point, but you may hear them all over that precordium. So make sure that you do a Z pattern going back and forth all the way down, or you can work your way up, and it tells you to make sure that you go from the base of the heart to the apex, or from the apex and work your way up. Now, one thing that I just said that I hope you paid attention to is the base of the heart. When we think of the base of the heart, we think of the bottom of something when we hear the word base. But in this case, it's actually more at the top is the base, and the apex is down towards the bottom, the way that the heart is lying. And again, we will talk about this more during lecture as well, but you can look at pictures in your book that talk about that. When you listen to these areas, make sure that you use the bell of the stethoscope. So just let your patient know, let your partner know that you're going to be listening. Sometimes it takes a while for you to be able to hear the sounds. As Jane said one day in lab, that we get so used to our most prominent senses, like we can see things better than we hear them because we're so used to being able to visualize. So it's often good to close your eyes as you're listening so you really focus on what you're hearing. So listening for heart sounds, we're trying to listen for 2 specific heart sounds, S1 and S2. There are other ones called S3 and S4, but those are really more advanced in figuring them out, and we're mostly wanting you to focus on S1 and S2. And as you listen over the areas, the aortic, the pulmonic, the tricuspid, the mitral, and Erb's point, you're going to hear S1 or S2 louder. So S1 is the first heart sound. So if we hear, if we think of the heartbeat going boom, 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 if I do it like that, S2 sounds louder. So the second heart sound would sound louder, boom, 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 versus boom, 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 boom. And that's where the first heart sound is louder. And in certain areas, you're going to hear S1 louder than S2. In other areas, you're going to hear S2 louder than S1. And typically when you get over Erb's point, you're going to hear them, you might hear them both equally. Sometimes you might hear one louder than the other, but most often they're pretty equal. So listening for those heart sounds, listening for those murmurs. When we're over the aortic and the pulmonic area, we expect S1 to be louder. When we're over the tricuspid and the mitral area, we expect S2 to be louder. And when you document that when you document your findings, I want you to tell me what area you were in and what you heard louder, S1 or S2 this week. And we'll talk about that more in lab as well. Aging adults may have different reasons as to why they may have cardiovascular changes. Gradual rise in systolic blood pressure can be common with aging. Not everybody has it, but it can be a little more common. Doesn't mean that it's necessarily a normal variant, but it may not be. It may just be something that we're not really sure why the person has it. But not all older adults should expect a rise in their systolic blood pressure. Usually the size of the heart doesn't change, but the left ventricle, the wall of the left ventricle can thicken. And it's usually, the left ventricle is the thickest anyways because it's got to pump the blood from the heart out to all of those peripheral areas, but it can get thicker as we get older as well. We may see some dysrhythmias, so some abnormal rhythms with age. If we're doing an EKG, you may see some changes on that. And then of course, we may see increased cardiovascular disease. Culture and genetics. We can have some culture or racial or ethnic considerations that might put people at a higher risk for cardiovascular disease. The same with family history and genetics. Some of them, for instance, those who might be more apt to get hypertension could be certain ethnic groups, racial groups, genders. Excuse me. Smoking has declined, but it still can increase our risk of cardiovascular system disease and disability and even death. High levels of LDL. So if we talk about our cholesterol, we have two specific kinds that we talk about: HDL, high density lipoprotein, and LDL, low density. And the way I remember which one is good and which one is bad is LDL. L means lousy, so that's the bad cholesterol, whereas HDL is happy, so that's the good cholesterol, and we want to have a higher amount of good cholesterol than the bad cholesterol. So increases in those, in the LDLs, the lousy cholesterol, the bad cholesterol, of course, can be an increased risk for cardiovascular disease. Obviously, obesity can be an associated risk factor. Patients who have diabetes have a higher risk factor, and women actually have the highest rate of death associated with cardiovascular disease as compared to men. Now, I think a lot of that might have to do with the fact that for women, the symptoms that they get and the signs are very atypical of what you would expect. They don't get that excruciating, crushing pain and kind of fall over like you see on TV. Theirs is more atypical. It may be more mild. It may be sustained over a longer period of time, but it's not usually as prominent, the signs are not as prominent as they are for men. So sometimes that associated death factor is, or the increased death rate of women may be attributed to them not realizing that they are having issues with their heart. So we talked about thrill, we talked about a lift or a heave. Those are some of the abnormal pulsations that you might find over the precordium. And this is just a little checklist going over everything. So it was a lot to take in, but it really boils down to looking at this, and these are the things that you are going to do when you assess your patients. So I believe that's the end of this. Yep, this is the end of this presentation. And I will see you in class, and we will go over a little bit more of anatomy and physiology. Have a great day.